Osteoarthritis is a chronic disease affecting the joints, characterized by degeneration of cartilage and associated joint structure changes. Normally, joints are lined with hyaline cartilage that helps to reduce the friction between the bones when the joint is moved. This cartilage is around 95% water and extracellular matrix and 5% chondrocytes, which are the cells that secrete and maintain the matrix. In osteoarthritis, this cartilage is damaged. This can be due to abnormal tissue remodeling after an injury, inflammatory mediators from the synovium affecting the cartilage, and defective cartilage metabolism, which can be the result of obesity. Overall, the mechanism is thought to be due to chondrocytes being stimulated to repair the cartilage, so they produce proteoglycans and collagen, which are the building blocks of cartilage. However, this stimulation also causes them to secrete enzymes like matrix metalloproteinases that break down the cartilage, as well as inflammatory cytokines that then cause further stimulation of the chondrocytes and perpetuation of the cycle. Eventually, cartilage is broken down and bone is exposed, becoming sclerotic and causing osteophyte formation in an attempt to stabilize the joint. The ligaments and tendons surrounding the joint become stiff and can predispose to tendinopathy and contractures, and muscles can waste and reduce the stability of the joint. Pain is the most common symptom, usually with a gradual onset. This often worsens with weight bearing and is relieved by rest. However, with progression, it can become constant. It is not commonly present overnight unless in advanced stages. Stiffness is common on waking or after inactivity, but it usually improves with movement and lasts under 30 minutes. Crepitus and a grating sensation can also develop. Any joint can be affected. The most common, however, are the proximal and distal interphalangeal joints of the fingers. These can feature bony enlargements called Bouchard's nodes in the proximal and Heberden's nodes in the distal, which I remember by Bouchard below and Heberden higher. The thumb carpometacarpal joint is also commonly affected, particularly causing pain and difficulty with grasping, as are the cervical and lumbar vertebrae, which can in some instances lead to spinal stenosis. Lumbar stenosis particularly can manifest as neurogenic claudication, meaning intermittent leg discomfort as a result of nerve compression. Others include the first metatarsophalangeal joint of the foot, the knee, often affecting the medial side first, and the hip, most commonly in weight bearing or rotation, such as when putting on socks. The pain can also commonly be referred to the groin or knee. Osteoarthritis can be divided into primary, also known as idiopathic, where the exact cause is not known, and if multiple joints are affected, it is termed generalized osteoarthritis. Secondary osteoarthritis can be the result of conditions that alter the joint structure or cartilage microenvironment. Examples include congenital joint abnormalities, significant trauma, other arthropathies like rheumatoid or psoriatic arthritis, gout, as well as metabolic causes like Wilson's disease or hemochromatosis. It is more common in females than in males and becomes more prevalent as age increases, with around 44% of people over 70 having radiological evidence of it. Other risk factors include family history, obesity, repetitive, excessive or abnormal loading, such as in professional sports or occupations, and physical inactivity has also been shown to be a risk factor. Diagnosis is mostly clinical, with imaging done to support the diagnosis. A clinical diagnosis can be considered if there is activity-related joint pain, no morning stiffness, or if there is, a duration of less than 30 minutes, and age above 45 years. Common findings on X-ray can be remembered with the mnemonic LOSS, standing for loss of joint space, so joint space narrowing, marginal osteophyte formation, subchondral cysts, and subchondral sclerosis. Blood tests are not needed for the diagnosis, but in cases of uncertainty can be useful as raised inflammatory markers or presence of other markers like rheumatoid factor or antibodies may point to an alternative diagnosis, like rheumatoid arthritis. Treatment is primarily aimed at reducing pain and improving function. Non-pharmacological management includes physiotherapy to maintain range of motion and improve the ability of the tendons and muscles to deal with joint stress during motion. Immobilization can promote contractures and so is discouraged, and weight loss can help reduce the load on joints and can slow the progression of disease. Supports like knee braces or walking aids can be beneficial in some cases. Pharmacological treatment is often used in conjunction with physiotherapy. This includes non-steroidal anti-inflammatories, with topical agents being preferred, and paracetamol are common first-line agents, though paracetamol in some studies has shown limited benefit. Topical capsaicin is an option, but is not regularly given, and duloxetine is an option if non-steroidal anti-inflammatories have failed or are contraindicated. Joint injections with corticosteroids can help short-term pain, but are associated with a placebo effect and can increase the risk of cartilage loss. Opioids are not recommended as the benefit in osteoarthritis does not outweigh the potential harms. Surgical options are usually explored after non-surgical therapies have failed, and can include total joint replacements or osteotomies.